Yes, can see.
Okay, good. There it is, 11 o'clock, my time, 7 o'clock yours. But we have like Sri Lanka on here. It's Bandu is at near midnight, so 11 p.m. his time. So uh, we just have to coordinate the right times. So thank you for your attendance and in advance and your dedication that you're going to spend an hour with me. I take it seriously because I know I don't want to waste people's time. I want you to learn. I want you to see what I've learned over nearly 50 years.
Funny. Funny.
It's a it's an honor to be able to to share what I learned, um, so that people can do better work and have happy patients and happy careers. And so that's a lot of my motivation. I've already been through the wars of malocclusion, and I just want to share and make it so that you understand what's coming. And I know many on here have already established very nice careers in the field of ortho. So let's get started. Our case here is, kind of the next step. Last time we talked about a class 2 deep bite case. This one has the um, additional concepts of a functional shift, in this case, a suspected functional shift, because there's no frontal ceph to confirm it. So the only way that you can confirm a functional shift is by having a frontal ceph x-ray, trace it, and then you see the mandible is to one side or another. And that means that you need to look at several other features of the case, and there are different ways to treat those. And if you understand them, then you can take a case that would otherwise be very complicated and have a lot of success. And it's very rewarding. Now, all the cases with a functional shift do not treat like we want. Okay, there's of those, there might be like 10% that are like resistant in changing the functional shift, and some of those are possibly a asymmetry of the jaw, the mandible being longer on one side than another side, and that could only be fixed if it's through jaw surgery. So the alternative is not very good. And I also see a lot of misdiagnosis in the specialty, particularly over the years, where they had extracted first bicuspid on the class 2 side unilaterally, and in order to correct it to class 1, this case on the left side is near class 1. Actually, the molar is a little bit class 3. And we also have the additional feature of tapered incisors. And you can see the triangular spaces in there. By the way, in Method Orthodontic Suite, I can change the like coloration. And some like this. I personally like it more like that. And I did a lot of this look because on exporting, if it's an STL file, this is what I get. If it's a PLY file, then I could get that. This would be a Medit scanner. You have that option. Some of the iteros, I can see the color, but for some reason, other iteros, I can't see the color. So, and then on some iteros, the color is not pretty at all. So, but but the Medit color is very good. The Medit itself uh, is known to be the very, very accurate. Is the most accurate of any of the scanners, and therefore, because it is, well, actually, I fear that 3Shape has the same level of definition of quality, um, and therefore those scanners are used more in restorative work. If you're using iTero for restorative work, the word is that I hear is that things just don't fit quite as well, and so I don't know why they think that you can make that larger and then that would be good for aligners. No, I think you need as much accuracy as you can get, and fortunately, Medit has that level of quality. Okay, so but I'm not selling any Medit machines, but Medit's been very good with us and has enabled us to make this make this software, and it continues. So um, we're very happy. Okay. So I've got this, and I usually, oh, and I've also imported a lot of images of the case. Let me go through those right now. Basically, it's a girl, a female, age 13, and she's growing. Okay, I trimmed it down, of course, for um, for privacy reasons, and the smile here looks fine. Upper incisor looks fine. I don't want to move that back. The upper midline is actually centered in the upper lip and nose, but the chin is to the right. If you're looking for it, if you're not looking for it, you'd miss it, of course. And then the lips, I think that they're closed pretty much at rest, but the lower lip maybe rolled out a little bit from the overjet. And oh, let me go back just to get that smile. We don't we don't see the full upper incisor, so we're going to be talking about the vertical in this, and the various ways to like correct the like deep bite, and how that relates to our bracket position and prescription, and if you were using an aligner, then where would you focus the programming for intrusion and that sort of thing. So we'll be talking about that. The In this case, we do not want to intrude the upper incisors further than where they are right now. So if you look at this deep bite, you say, oh, I want to intrude the upper, I want to intrude the lower. No, you don't want to intrude the upper if you don't have to. So we're going to be talking about the like bracket prescriptions and how they relate to this, and how they relate to the occlusal table and embedded orthodontic suite. So, so we'll do that. And here is the photo that you can see quite a bit more, of course, on the scan. And once you get used to being able to see not only the lateral view, the buccal view of the molars, but also the lingual views, then you can't go back to just photos because you can't usually see that. If I look on the lingual view here, the mesial-palatal cusp is not quite in the central fossa of the lower molar, the lower first molar. So it's maybe 1 millimeter class 2 from the palatal view, from the lingual view, whereas on the like, buccal view, it looks like a 4 millimeter class 2 molar, and since the molar establishes where everything else erupts, well, you have a class 2 going forward. Okay, so that's part of the characteristics of this case. The same thing on the other side, but this one, if I use my imagination, this looks like the mesial cusp would fit right into the buccal groove. So that's a class 1, and from the buccal, it's a little class 3. Okay, so you have different classifications, buccal and lingual, and then the lower incisor is in contact with the palatal tissue on the upper. Okay, and I haven't ever had that myself, but that doesn't look too comfortable to me. Okay, so then going forward, we have the lower midline to the left of the upper midline. So then we say, all right, is the upper midline is that centered, or is the lower not centered? It's either one or the other, or maybe both. So part of your diagnosis is going to be looking at the mid-palatal suture, looking at the face. Let's go back to the face. I already said it looked like it was centered. It looks like it's centered there. And in just a few moments, we're going to have the panoramic, and we'll look there. And then I want you to train your eyes. You have to train your eyes to do this. Whenever you see the upper and lower midlines not centered, the next place your eyes should go is at the cuspids. And kind of difficult to see in that photo. So I'm going to bring up the daylight scan again. And here I can kind of, change the angulation so I can see. And it's not very obvious, but at least here at the cusp tip of the upper cuspids, it looks like there's more horizontal overjet on the left side than the right. Now, one advantage of our simulations that you're going to learn is that some functional shifts that wouldn't be obvious if you just are looking at the teeth. When you straighten the teeth in the alignment level alignment simulation 1.1, you will see functional shifts or differences in the cuspid right versus left that you could not see just glancing at it. And I think you'll probably agree on this one too, that you can see it more clearly in this case. So I don't have a frontal ceph here. It was not sent to me. So it becomes a suspected functional shift. In other words, I don't know for sure, but it looks to be from certain characteristics, lower midline off center to the right, to the already centered upper midline, more horizontal overjet on the left-hand side at the canine than the right side. And it's just about the same amount of difference as the midline, and then more class 2 on the right side than the left. Okay, there are 3 characteristics right there that will be consistent, and I see this like probably about 20% of the cases. I'm just guessing, but I haven't counted them or done a study to find out how many, but it seems like about 20% of the cases it's like all the time, not every case, but it's something to deal with. Now, if you do deal with whatever the cause is, and you correct that either orthodontically or through an occlusal adjustment, all of a sudden your case becomes much easier. And so it's important for you to see these before you start, so you can make the plans to identify where the problem is, try to get that taken care of, and all of a sudden, maybe you don't even need class 2 elastics. And it was a class 2 case. You say, what happened here? I can remember being pleasantly surprised in the clinic when, I would give somebody some class 2 elastics, and or it was planted, and all of a sudden they didn't need it anymore. And I go, well, isn't that a gift for today? But now I know kind of the features and why that could have happened. All right, let's keep going. So class 1 left, class 2 right. And so the issue is going to be, do we have symmetrical dental arches? And we're looking at the molar in particular, right versus left. And if we have like symmetric dental arches and we have class 2 on one side, to give those features, since the upper can't move, the lower has to twist. And when it twists, is twisting because something is interfering in their bite and they're trying to avoid it. And when it does twist, it also pushes back posteriorly on that class 2 side and then compresses the TM joint, and then they can have jaw joint problems. This is very important. It's a very important part of orthodontics that is not trained in the specialty. The specialty generally doesn't know this. So, but this is really important. Okay, so very little crowding in this case. It's all pretty much a functional shift. Class 2 deep bite. We haven't looked. We've looked a little at the deep bite. We'll look at more. And so so on the panoramic, I look at the second molars. That's where my eye goes first. You have to train your eye, as I already said. Midline is off. Okay. Is the upper centered? Well, here's your mid-palatal suture right here. And that looks like the upper is centered, just like on the facial, the smile photo also showed it to be centered. And then, so then what could possibly cause the mandible to want to shift to the right? Well, I see a second molar here that is super erupted above where the first molar is. There is a contact. On the left side, I see a mesial inclined lower second molar, and I see that a lot. And the occlusion with that against the upper first molar can cause an interference that makes the mandible want to shunt to the posterior on that side, one side or both. This one with the mesial inclined second molar, it could have erupted, come in contact with the mesial coming in contact with the distal of the upper first molar, and then, but the tooth still wanted to keep erupting, and it ended up with this mesial inclination. The second cause could be a third molar was pushing on the crown as it wants to erupt, and that could be happening here with these third molars, and the lower second molar comes in before the upper first molar, the upper second molar, excuse me. I'll say that again, the lower second molar erupts before the upper second molar that comes in contact. So that gives an opportunity for a super eruption of the second molar. So we see this a lot. So that will give you reasoning to band or bond the lower second molar in particular. The upper second molar, not so much, but definitely the lower second molars. This case, the request was for brackets. We're going to investigate brackets. We're also going to talk about aligners and some of the features of each that work in the treatment of a functional shift. Okay, so we have here everything really clean, not even any decay. We have a super erupted lower second molar, a mesial inclined upper first molar, and this happens to be the one that was rotated, and I suspect that was also due to the occlusal the interdigitation during a period of growth when the mandible's growing forward and the upper E is falling out, the baby tooth is falling out, and the upper molar is wanting to rotate around the palatal root. And this one did it on one side. One side. And that happens to be the side with the class 2. Interesting. So we have more molar rotation on the upper right, I think, than the upper left. Anyway, I might have that wrong. Okay, so those are the features of the found on the panoramic. Are there any questions so far? If you do have a question, you look at the little microphone and then you say something, and then after you get the answer, turn it off. Okay, I'll leave mine on. All right, so the next is the cervical vertebra. Now, cervical vertebra, of course, is coming off of the lateral ceph, but I made a screenshot of this one. And so I call this stage 3 growth, which is a period of rapid growth. And we will talk more about that. But right now, you need to be able to distinguish not only is this patient a growing patient, even though she has all of her secondary teeth, she's still growing, and then try to identify what is going to what might happen to you during treatment that is important for your planning. So this one, I basically look at the inferior of the C2, C3, and C4, and see if it's flat or curved. This is very curved, very distinct curve. So 1, 2, 3. That's at least stage 3. It could be stage 4 or 5, but it's at least stage 3. If you have flat on one of them and just 2 curves, well, that would be stage 2. Just in your mind to quickly do it so you're not having to refer to diagrams, okay? And if there's only 1 curve, then that's stage 1. And so to distinguish between stage 3, 4, and 5, we look at the height of C3 and 4 particularly, because C1, well, we can't look at that height, but 3 and 4, we look at that and then compare that if it is square or if it is shorter in height than it is in width. This one looks to me like that is rectangular, and it's not as tall as it is wide, okay? So I'm going to call this stage 3. If it gets taller on one of them, then you say stage 4, and if it's taller on both of them, then you're stage 5. Now, it's really difficult sometimes to tell between stage 3, 4, and 5. The best way is with a wrist x-ray, and that's very distinctive as far as which joints have calcified and which ones have not. But we don't have that here. And I get wrist x-rays, but we don't have one here. So we work with what we have. So this I'm gonna call her stage 3. We'll have another opportunity to confirm that or think it's reasonable or not. And that's gonna. So here's our lateral ceph with skeletal and dental closed bite with excess overjet. Do you see that? And the nasolabial angle looks normal. We would love to see the mandible grow forward. And some might even say, oh, he needs jaw surgery. No, she needs jaw surgery. No, she doesn't. But we're here to fix her teeth. And you can see the curvature on the lower, especially. and then it has a more mandibular retrusive look. We're going to measure that and see if it actually measures a skeletal class 2 or not. But for the moment, we have a deep bite dental, we have a deep bite skeletal. And all that means is things are going to be, you're having to move the teeth within tight muscles. And if you're leveling the lower arch, those tight muscles will prevent or reduce the amount of extrusion of the bicuspids in the middle of that curvus B, and you have to wait for the intrusion of the anterior, and that can take some time since teeth are made so that they will resist vertical forces of you chewing on them. Otherwise, everybody would have already flattened them all out. Okay, so that's going to give us some information. We're going to trace that in Method Orthodontic Suite. Here's a little diagram of a functional shift. The condyle on the left side would be pulled out of the fossa slightly and then rotated on the right side, as you can see here. Okay, exaggerated. This would be a severe one. And this is what you may be looking at here, through the functional shift. And the reason why, so it not only rotates, but you get a posterior like displacement on this side, and then it's going to look more class 3 on the other side. And there's your little class 3 molar there. Okay, so there's that. There, now we're just looking at the scans that you can see now visually. We may want to refer to them. I've already covered all those. Now I have not covered this one. This one is showing a severe or a deep lower curvus B. Okay, and I think all of you would classify it that way. On the upper, it looks to be pretty flat. Now remember, we did not in the smile. We don't see the full central incisor at the high smile, and that looked like high smile. So we really don't want to be intruding the upper incisors when you have a flat occlusal plane on the upper occlusal table, occlusal table on the upper jaw. But here, if you put a flat occlusal table there, well, you've got a lot of tooth movement to do. Okay, so the deep bite in this case is going to be mainly focused on the lower arch, and we just have to be careful not to focus it on the upper arch. Here I drew a line between the distal buccal cusp of the lower first molar and the buccal cusp of the lower first premolar. Now that is officially called a functional occlusal table. Now what you're looking at is an occlusal plane, but in 3D, going to the opposite side, the whole lower arch is an occlusal table, and we're going to see that in Method Orthodontic Suite, and we're going to likely be adjusting that occlusal table. And then you look at this and, oh my gosh, well, what's the second molar sticking up so far for? Relative to what? Relative to the occlusal table. Now, I could have chosen a different occlusal table, and then I'd be extruding these teeth in the middle, resisted, of course, by the muscles of mastication. This is where the chewing is, and that's why they call it the functional occlusal table. Okay, so let's go to the next one. Let's see here. What else we have? The lingual, as I already mentioned here. This is where my eyes are trained to go, and that was not throughout my career. This was just in the last, I don't know, 3 or 4 or 5 years, something like that. But in a 50-year-old career, well, that's only in the last 10%. Okay. All right. So there's that. That's where I've trained my eyes. And you really don't see that unless you're told to look for it on study models, or I didn't see it until we were looking at 3D scans and focusing on molar rotations on the first molars. Now, if you don't have a functional, no, if you don't have a frontal ceph and you're looking to see if you have asymmetry on the face, this is the next best. You basically draw a line. I drew a big line through this for privacy purposes. It'd normally be the small line, and so you draw it through the center of the eyes, the pupils, and right between the eyebrows, and then right between the upper lip, and you can see that the upper midline is centered to that line, and it's confirmed by the mid-palatal suture that we saw on the panoramic. And then you look and see how much chin you see on one side versus the other, and I can now more clearly see more chin on the right side. So to me, that just adds evidence to the suspected functional shift. The midlines are off, the upper is centered, so the lower must be off. More horizontal overjet on the cuspids, right versus left, with more overjet on the left side since the mandible is shifting to the right. I am looking at class 2 on the right versus the left by a difference of about 4 millimeters. And I haven't got to the symmetrical arches yet. I haven't determined whether or not this suspected functional shift is really a functional shift, because I have one more important thing to do, and that's find out whether or not there is symmetry in the two arches, upper and lower, because some of these have what I call like triple asymmetry. They not only have a functional shift, but they have a lower arch that is asymmetric on the teeth, and then they have an upper arch that's asymmetric on the teeth. Oh my gosh, those like fry my brain trying to figure out which way to fix it, how to fix it. Okay, so this one is actually easy because we're going to see two symmetric dental arches, and then the mandible to the right with those characteristics that I just described. Okay, so here's an aligner. This is one thing that we can do to break that pattern. We can put some or just ask for some bite ramps on the upper. This one is placed from 2 to 2. If there's too much overjet and you can't reach the lower teeth, then you put the bite ramps on just the cuspids. And then if that doesn't work, well, then you bond composite to the lower in what's called an occlusal pad, and then you use that to prop open the bite. Now, if you're using brackets like this one, then you can, let's see, out of order. Here we go. So this would be an aligner, but you could do the same thing with brackets. This one is only on the two centrals. It's solid. The other one is hollow. So if this you could do like freehand if you wanted, and then it would bite the lower teeth. The lower incisors would bite this first. That would be an active bite ramp, as opposed to just asking for them in the aligner. Or you could use this mini mold attachments kit that has a bite ramps of 3 millimeter and 5 millimeter, and you use composite to place it on the palatal of the upper teeth to break the functional shift, actually, and also to help you level the lower arch. Any questions about that? Oh, here's an occlusal pad in an aligner. They leave a hole in the aligner, and then you fill that with composite with your little template. And but the problem with that template from my progressive aligners is that it's a little bit curved. There's a little indentation for the palatal cusp. I'd like it to be flatter, but I can't change that. So I can change it after you place it. You take a burr and like flatten it so that the mandible's free to move from side to side. Now, if you're using brackets, we call that occlusal composite, but it's the same as this pad. And when they remove the aligner tray to eat, well, guess what? All they bite down on is that pad, right? So you're saying, wow, okay. So in other words, uh, in the differences of being able uh, to deal with the occlusal interferences and sort of break that. You can do that with aligners, and that's a little easier because, uh, uh, especially on the bite ramps, because you just ask for the bite ramp, it comes built into the tray, nothing to do. Um, whereas the the like occlusal pads on the molars, well, they're like similar pretty much on the um, for the brackets and the aligners. Okay, you're still bonding composite. One you have like a template to actually pack the composite into and place it, and the other one you just freehand the amount of composite that you're putting on the occlusal surface. There was some confusion, or there has been some confusion, how thick to make that, and I have described that a couple ways. Um, One of them is a millimeter thick. That seems to work pretty well. They understand that. Another one is uh, uh, a, a thickness that is that that is until the occlusal um, to the cusp tips. Okay, so you just fill the light depression to the cusp tips and make it flat right across. And so, some people, it's easier for them to think that way. Okay, but those are a couple ways to make that happen. And I put these pictures in here just for that. Now, we really haven't got to the molar rotation, but let's do it right now. Can you see the molar rotation here? I hope so. It rotates around the palatal cusp of the tooth, and either by the occlusion with the lower and or the waiting for the five to erupt after loss of the primary molar. Uh, Instead of the lower molar like tipping forward and rotating a little lingual, the upper molar just basically like rotates to the mesial palatal. Okay, and that's what causes that. Um, so when you want to derotate that upper molar with brackets, we have a distal offset, it's called, built into the upper first molar brackets, and that is a 10-degree distal offset. In the old IP, back when we started, it was 8. So we added like 2 more degrees, and sometimes I like it even more than that. But because on an aligner, you can just tell them, we want more distal rotation. We want more, okay? And you can go 15, 20 degrees on an aligner. It doesn't matter. Whereas you're limited somewhat on the bracket. So this is a upper expanded ovoid, our 10th arch form in the IP system, added, I think, a year or two ago. and you can see that it has a curve in at the first molar, so it will enhance the distal offset that's built into the bracket of 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 like 10 degrees on this side that does not have the molar rotation that's as obvious. You can see that the arch wire is kind of parallel to the buccal surface. So this side would get like 10 degrees. This side would get maybe 13 degrees or 15 degrees, somewhere in there. In other words, 10 degrees due to the to the bracket, and maybe a little bit of curve to enhance it from there. Okay, now that was one of the arch forms that I could have chosen in this case, and I want you to know in MOS where that is and how to distinguish, because it's a little different. It's not obvious. Okay, so this is the expanded ovoid, and that is the widest arch form that we have today. Now this one is our non-extraction ovoid number 1 on the same case, and you can see that the arch form curves in, adding to the distal offset of the 10 degrees in the bracket slot. Okay, and for that reason, I chose expanded ovoid. I'm sorry, I chose non-extraction ovoid number 1 that you're looking at right now because of the molar rotation features. Okay, as opposed to the other one. Now we'll see that in just a moment in the Method Orthodontic Suite. Okay, so let's get into our Method Orthodontic Suite. We will process this now that we know some of those concepts. We're looking here to intrude the lower arch. We're looking to intrude the sevens. We have some molar rotation here. Okay, so let's see what we want to do. Well, before I start that, I want to clean up this. So I'm gonna trim. I trim in Method Link, although you are, which I'm at right now, or there is a place you can trim in Method Orthodontic Suite, which is up here on the upper left. Okay, which we're going to next. So I'm gonna trim first, and I'm trying not to trim one arch at a time. Okay, if you do that, you have to save and then come back. So I kind of take that off and I say, okay, that looks good. If it doesn't look good, then I can always click the undo button. Okay, that looks good. What you have to be careful of is that you wipe out something that you want on the opposite side. I'll go ahead and do it. I wipe it out, and I go, oh, wait a minute, I wiped out a couple teeth. No problem, undo it. Okay, undo. And then you come in and then rotate it, and then like clean it up a little bit, hopefully without having to go to the upper arch and the lower arch separately, because then I have to save at each time I do that. Okay, so now I can see the lingual, I can see the I can see the inclination of the molars, and that's kind of why I wanted to trim that. And then I feel like I probably want to trim that little excess data out, just so I can kind of see where the gingival tissue is, anterior and posterior. Okay, so I did that. I saved. Done. Now, when I click on Method Orthodontic Suite, have an opportunity to put in into the into the simulation software, all these little items, which you're going to see here in just a second, I hope. And I have to change the screen. Can you see that or not? Can you see a whole bunch of pictures here on the left side?
Yeah, we can see it.
You can see it?
Yep.
Okay. All right. So now I'm going to slide over the lateral shaft, and then the panoramic I'll put down here because I may want to refer to that. Might as well throw in the growth. Why not? I don't need any of these in there. Maybe I'll throw in this little diagram. Why not? And the asymmetry I may want to refer to. So in other words, you just build your case with the important photos. I've got extra ones in here, of course. Let's see, I missed one. This one. This one. Okay. So I think I've got all those pretty much in place. And oh, we need the lingual ones, don't we? Let's see here. Lingual. Oh, maybe I had that. Both of them. I'll throw that over on the x-rays. There's no problem. It doesn't read that it's an x-ray. It just says it's a JPEG, I think. Okay, so I've got it all there. All those extra photos are going into the orthodontic photos section here. And then the scans, they stay here. All right, I've already trimmed, so I automatically just, if there's holes, you can fill the holes too. But this is a nice scan, nicely done. AI chose those points for me. And now it's my job to confirm the amount or adjust the amount of vertical. So I'm going to do that by, you can see here, the occlusal table is showing that there needs to be a lot of anterior intrusion. There needs to be intrusion of the second molars, and it already chose those points. If you don't like the points, you can detach the data and just place them where you want. This one's an easy case. Now, to check the vertical, I'm gonna click on the left side here. It says maxilla group, and here I can see that to be set to the occlusal table, I would have to intrude the upper incisors slightly, only maybe a millimeter, but still, we don't want to intrude the upper. So let's just rotate that up. For that, I go to the lower right diagram. I hold down the left click button. And I rotate. And now the upper incisor is right on the central incisors, right on that occlusal table. It's not going to intrude it at all. Now, this is important in not only brackets but in programming for the aligner. If I am using a aligner, there will be no programming for intruding the upper incisor. It'll all be programmed to intrude the lower incisor. If I'm using brackets, I choose between 51% deep bite bracket positioning and 81% bracket positioning. And you know that you get closer to the incisal edge when you go on 81%. Okay, so let me explain here. 51% is leveling the lower arch with your bracket height consistent anterior to posterior. It's 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 leveling that lower arch, but you're going to have a certain amount of inefficiency, and so to overcorrect the leveling of the lower arch, we we can use 81% deep bite, and those numbers are actually so that you get a reverse curve of speed on the lower. Are you going to see a reverse curve of speed? No, you won't see that reverse curve of speed. You'll, but it's an overcorrection, so you can level that lower arch. Okay, but in the 81%, you're also putting the upper brackets more towards the incisal edge, uh, and so you are creating a little bit of a negative curve of speed in the upper. In a case like this, I would like to probably go 81% lower and average upper, but and the upper is the same on average or 51%. So you could go 51%, but you're not going to get a full correction of the lower arch leveling, or you can go 81%, and that'll overcorrect a bit for the inefficiency of the arch wire. And then of course we have 014 reverse curve NiTi. Used to be 012, now it's only 014, and of course that is also causing a leveling of the lower or upper arch with extrusion of the premolars, intrusion of the incisors and the molars. So it looks to me like this is what I would want. I'd like 014 NiTi reverse curve in the lower, and if it's too much intrusion, well, then you've got to start thinking skeletal anchorage. So let's take away that. That's a lot of intrusion. That's asking a lot, okay, to intrude those lower incisors in a skeletal closed bite case that much. So this is kind of in the range of um, uh, of of needing lower skeletal anchorage. Okay, not upper, lower. Not upper because we like where the upper incisor is. We don't want to intrude that. Okay. So this is setting the occlusal table, and that is dependent on how you are going to treat the case. Once you set this, don't change anything, because if you do, then everything forward you have to redo, because now this tells it where all the teeth are supposed to be set to. Any questions on that? Oh, look at this. It was a nice scan. It was a meta scanner. And I go, oh my gosh, how could it miss all those teeth? You know? Well, it happens once in a while. What happens, I believe, is that they uh, that that the AI software doesn't recognize where the margin is between the the tooth and the gingiva. It's not distinct enough. Okay, and so it doesn't separate the teeth. All right, so that's okay. We just have to do our work. So this one is totally in the wrong place. So I go, well, let's get rid of all that. Okay, and then in MOS we have the smart tooth selection, amazing tool, and you just sort of like click it, and you can see it got a little under and a little over splash here. So there, I'd probably take my minus brush, clean that up. It's okay if it's a little short. The problem is if it's hanging out there. Okay, if I really want to be like particular, I could use a positive brush, and I could do that. Okay, while I'm at it, might as well get the minus brush and clean this one up. Again, this is because the AI doesn't recognize uh, the margin of the tooth where it changes from gingiva to tooth, and this is why your scan is so important to make it go. Okay, now for me to get teeth that were completely missed, I have to do those one at a time. So if I have 3 in a row like this, I do the middle one. Find teeth. There we go. Boom. Found it. Did a good job. Okay. And unless you want to take your brush and paint the whole tooth, that takes a lot of time. You now go to find teeth and that one and find teeth. Oops, a little over. Let me just try that again. It did a better job a second time. You see that? So actually, I'm okay with that. And then I'm looking interproximal. Make sure there's not a lot of big bumps or something. You can see I'm leaving a little bump here. I'm not manufacturing a tray. If I was manufacturing meted aligners, then I would need to like refine all this missing tooth stuff. It become more important. Since we're doing brackets, requested brackets, then but you could do aligners. We'll go through that. Then you don't have to do all those little details there. Okay, here I'll take the middle one again. 3, 2. Good job. Okay, I go back. 3, 1. Let's go get that one. Ah, try it another way. Ah, see, I don't want to get my minus brush and do all that work. That's too much. Oh my gosh. So I guess what I'm going to do here is I'm going to take my brush and tell the AI where the tooth changes from like enamel to gingival tissue. And interproximally, I want things to be clean. I don't want there to be big bumps on the tooth. Because that can mess up whether or not you get spaces or not, whether roots are clanging each other. So you see this little overage right here? I don't have a like distinct contact. It overflows into the next tooth. I don't want that. Okay, I got one more tooth, I think, to identify. And then we should be okay. Fine teeth. Okay, did a good job there. Oh, here's some overflow. Let's get rid of that. And again, unless you were manufacturing, um, which, from a scan, which is embedded aligners, not in progressive aligners, there you have a designer to do all this for you. Okay. And actually, I think somebody before the designer does all this. That's their quality check there that they go through. All right. So do we have growth? Yes, we do. But I was not prompted to, to put in the like growth information because I think she's 12 because I did not indicate any of the teeth were a primary tooth. If you indicate a primary tooth, it makes you put this in. Okay. Now, I said stage 3, 12 years old. But guess what? There it is. Even if she was 13, I'd say I'm going to go by stage 3 here because it was a pretty distinct cervical vertebra. If you don't have a lateral ceph or a wrist X-ray, this is an opportunity to add growth right into your simulation by just choosing the like gender, the chronological age, the like skeletal age, all of which are included in the growth calculation. And if I said male instead of female, see that changes, the ages changes for stage 3 from 12 to 14. So the males are about 2 years later. Okay. So there it is right there. Oh my gosh. I'm already at the hour. Okay, speed it up here. Okay, I'll keep going. That was my alarm. I talk too much, huh? Okay, let's go. Sorry, everybody. Okay, so now I've got the AI lateral ceph, and for growth, I need to do like Candilion. And let's see, A point, B point's important. All these little red dots, they're important. A point, I got that. And then the molar, the width's very important, okay? So the width here is one of the features. So is the maxillary length. So is the mandibular length. Is measuring it behind the seams, and so is the McGann growth factor. That is a combination of those times the angle there. Okay, which made a very accurate growth prediction. Okay, so if this is actually sitting there pretty well, I can take my little like scroll on the left hand side, and I can kind of gray it out so I can see maybe the lower or the upper. You can see the lower incisor. If you want to change that, which I doubt we have to, but I do one on the X-ray, the same one on the model. It's about the same, maybe a little nicer. Okay, width is 1.8. That is normal. Green light, green traffic light. We get some red traffic light here for the skeletal closed bite. If you want to know where that is, you look here on the sheet, and this is the angle measured. Okay, and then we have an upper 124, and you say, well, wait a minute, I don't know what that is. Well, this is the angle there. And so you go, oh, okay, 124, that looks like the upper incisors proclined. All right, next. Okay, medium ovoid, symmetrical, two symmetric arches. Without doing model measuring, I just go right there, boom, it's all done. I already know the symmetry, right versus left. So this is medium ovoid. Now, if I want to do expanded ovoid, remember that? Okay, there's our expanded ovoid, and I can. It's actually pretty accurate. It just takes it where you already moved it. I can slip back into medium ovoid with a click of a button, or I can look at non-extraction number 1. Now, remember the non-extraction number 1? Let's see here. Where was that?
You just have to scroll down, I think, on your pictures there, Don, or up or down. Oh, maybe you didn't drag it in when you were setting up the case.
You know what? I didn't drag it in. Okay. Anyway, you remember that we've been using that arch wire for a long time. It curves in on the first molar to increase the molar rotation. Think that was an accident when I did that way back in, I don't know, 1980 or something, I think. No, because this was a class 2 elastic practice in those days. And so you needed that molar rotation on the upper. You needed the molar rotation on the lower to like counteract the class 2 elastic force. So anyway, it is not curved in MOS, and you need to know that, okay? Because we straightened that out. Otherwise, it made the posterior teeth look all strange on the actual curve, which we do not see clinically So we straightened it out. That took some time. Now I'm going to select non-extraction number 1 in this case. So let's
You stop
do
showing your screen.
huh?
You stop showing your screen.
We lost the screen?
Yeah, share your screen again.
Oh. Wonder what happened.
There you go. Good
Got
now.
it back?
Yep, got it back.
Okay, so I'm going to put medium ovoid on here. AI now is showing me a class 3 molar on the left-hand side. It's showing a class 2 molar on the right-hand side since it's more than 1. Okay, and so you say, well, let's see. Is that okay? Well, this one, AI might have missed the mesiobuccal cusp a little bit. But yeah, it's a class 3 molar. So now it says class 2 because that took priority. Before, you might have noticed that took class 3. Now, what this down here is indicated class 1, 2, or 3 dental is factored into the growth. It also determines which simulations you're going to see, what options you're going to have in the next simulation preview window. So the most important thing for you to know is that at a plus or minus, no, actually, on a plus 3 class 2, if you go over that, you lose your class 2 elastics options. On if it's class 3 more than 2, then you lose your class 3 options on your elastics. So just put that in your head. Okay, so we're going to see the class 2 elastic options, and that's going to help us with the functional shift. So part of what we are doing here is showing you how to identify functional shifts, how to get an estimate of what you're going to get, and how to interpret that, what you're going to have to do in our study club here. So this is 100%. The T set to the occlusal table that we started is mostly going to be intrusion of the lower anterior, and it's got 1.55 millimeters of bite change due to growth. So do I believe that? Yes, I do. Now, if you don't get 1.55, let's say you get 0, well, then you're going to have to use some class 2 elastics. That's all it says. Okay. In other words, it didn't help you by that much. Now look at the cuspid overjet here, left side versus right. There's your functional shift. It's about the same amount on the lower midline to the upper. If I now click on simulation 2.1, which is arch form to maintain, class 2 would be the simulation 2s. You'll see the midline improve. See that? The lower let slipped over there a little bit. Now we have a little bit of class 3 molar. But the cuspids are class 1. Overjet, a little tight. Okay. So you say, well, if I want to reduce that, then I could go back and I could reduce the number here for the class 2. So let's go, before doing that, let's look at our Ceph overlay to make your treatment decision. Now, the lower molar has come forward. That's a combination of 1.5 millimeters of growth. That's how it's represented, not by the jaw coming forward. And maybe another 1.5 of class 2 elastics. Upper incisor coming back. That's basically due to arch form, molar rotation. The upper molar, you can see, has changed. Here's the start at the left. The molar rotation has changed, and now all that creates a space mesial to the molar, and all this class 2 gets pulled back, and a little bit of growth and a little bit of class 2 elastic, and now my class 2 is gone on that side. I cannot flip it to the other side. I have to do that by going back to this side, and then I say, okay, that's what the other side looks like. So that could be a treatment option, or a treatment decision, or you say, maybe I want more overjet. By the way, look at the triangular spaces of the upper incisors. Remember, they were tapered, so you can see that the edges are at an angle here. So if you're going to straighten out the edges, you're going to get that big triangular space again. This is kind of more of a compromise, like this one right here. That's a pretty big space with the lateral incisor with a straight incisal edge. You can adjust that either with the tools that you're going to see in a minute, or by just changing the angulation, and you can move. If I move to get those incisal edges straight, then I'm going to see those triangular spaces that probably would need would need some veneers afterwards, or bonding or something. I don't know. Would a patient ask you for that or not? Maybe, but at least you know it going in. Okay, I got too much overjet. I'm going to take you to some tools here for a moment. And before I do that, let's look at the brackets. The brackets tell us LISLA. So you say LISLA. Let's see, does that make sense? We got skeletal class 1. That's actually a combination of the advancing limit of the lower incisor and the retraction limit of the upper incisor. It doesn't tell you if this is advancing limit or retraction, but this is ideal inclinations on this, okay? And then it also gives you molar band tubes and rotations already calculated for you without there being a were you able to see that? Or did it go away with the screen share?
We can see it. No, we're still good.
You're good? Okay. Now you got me worried. Okay, aligners. I'm going to click on some IPR tools. If I was going to use aligners, you know, that's a reasonable amount. Let's see. Let me just look at that lower here. How many would I order if this was approved? So I go, the lower is one where all the movement is. I go, okay, click, click, click. It's kind of opening everything up, expanding. Remember, this is an expanded arch wire. This is actually expanded ovoid. This is expanded ovoid arch form, not non-extraction number 1. And probably right in here, I'd say take another scan. And then right about in here, the lower incisors start going forward. See, the molar already started going forward right about there. So at about 14, I want to start using some class 2 elastics if necessary. So this would be a good transition time. Take a new scan, and this is going to, and then you could refine all the little rotations as you use your class 2 elastics. what you do not want your class 2 elastics doing is when you're trying to rotate teeth, you need space. And if you're using class 2 elastics during that time on an aligner, you're going to lose that space, and then the teeth don't rotate. Then you lose tracking, and then you start over again. Don't pass go. So then you go back here, and then you get things kind of organized. And I might have to do a little like finishing aligner back in here sometime. You can see there's still some class 2 elastic movement, but that could be the growth moving forward. You see the growth moves forward, the molar.
Hey Don, can you show us the Ceph overlay on this setup and just like, yeah, is growth. So they've taken the growth and they've actually programmed it into aligner staging then. So when we turn on growth, I guess it'd be one thing for planning, but it's another thing if we actually want it programmed into the aligner staging.
Yeah, if you, but actually it doesn't really make a difference because, except that you don't want them programming in the like class 2 elastics. That is the growth. That's a good point, Collins. Since the lower molar is moving forward,
I mean, you may not get that much growth, so it's not a bad thing that it's programmed into the aligner
no,
staging, but
what you don't want is a dental movement for growth.
right. So they've taken that growth and they've made it a
So,
dental alveolar movement with the staging.
so this is a growing patient, and if the functional shift corrects the class 2, you don't want a dental movement of the lower molars going forward. Right here, you see the lower molars going forward? You don't want that.
Yeah, so
Okay.
all the better reason to batch order and do, like you said, the first like 12, 14, because then you can reevaluate the bite. You can put some bite ramps on there on the incisors so that you can get a new look at the case after the first, 14, 12, 14.
Yeah, and you may see, especially if you have some bite ramps or something on there, that that the functional shift like corrected, and you were able to do some leveling on the second molar, and all of a sudden, and they're biting on plastic instead of on the teeth, and now the mandible has a chance to center. Okay, now. Uh, this is a bracket case, okay? So on a bracket case, you would have to bond composite on the lower molars and then smooth it off, flatten it on both sides, articulated paper so that the mandible was free to move, okay? And if you were going to order aligners, you'd want to turn off growth. How would you turn off growth? Right here. You just go, it's not a growing patient. Done. And now when you go to order the aligners, well, they're going to be made at simulation 1.1. That's right, they'll be made at there. And then that's what you'll use for your first series of trays. And then you may add mechanics for class 2 elastics on your second series of trays. When you're using brackets, you don't see all this, okay? All of a sudden, one day they walk in, you go, "Oh my gosh, there's no class 2 on the right side. What was that? Now the midlines are centered." Well, looks to me like looks to me like there was a functional shift in it, and it corrected. If it didn't correct, then you have to help it along with some unilateral class 2 elastics, maybe an anterior cross elastic at night, and occlusal adjustment, looking for the reasons why the patient wants to bite that way. So you put some articulating paper in there, have them bite down, slide to the center, and have them point, hey, it's hitting right there. Get out your grinder and grind that off until they can freely move, and do it again at another visit, 2 or 3 times possibly. Okay. And I think if it's not correcting, it's usually because, I mentioned probably 10% of them don't correct, and I can't get the students sometime to grind aggressively enough. They're afraid to grind off the enamel. Okay, I mean it's not a laughing matter grinding off enamel, but that's it. Okay, so if you want non-extraction number 1 instead of expanded ovoid in the simulation 2.2 expanded arch wire, you have to indicate non-extraction number 1 here, and then you choose an arch form to maintain, simulation 1.1, I mean 2.1. Let's see, that was medium ovoid before. If you do 2.2, then you get the expanded ovoid. So this is this is non-extraction ovoid number 1 with more molar rotation. This is expanded ovoid. Okay, and you just have to know that you're not gonna see it change over here in arch wire. It's still non-extraction number 1, where if you go to the bracket output, expanded ovoid. Okay. All right. I think I've, let's see, I didn't do the IPR 3D tools, but the 3D tools, if you want, let me just do it here in about two minutes. If you want to see what lower IPR you need to do, even if you're using brackets, you indicate aligners, and that's where the tools are. There we go. Okay, well, let's go here. And now you say, I want more anterior overjet. So you click on IPR, you say, I want here, 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 here. 3 to 3, let's say, okay? Now, is that enough overjet if you just do 0.2 from lower 3 to 3? Well, you say, no, I want maybe more than that. So now, with your little roller button here, you expand it so that these little boxes separate. And now I'm going to change it to 0.4 on each one. And now you've got plenty of overjet. Okay, do you understand that? So that is your IPR tool. Even with brackets, you would do that. You could also reduce some of this, some of the taper, the triangular spaces, but now you have to take your strip and you have to do your IPR up at the gingival there, and there's not a lot of thickness of enamel up there, no more than 0.3 per contact, I think, right up there. But you can improve this, you know, the triangular spaces on like tapered incisors by doing a little IPR up in this area here. Let me just show you that. See that? 0.2. 0.3, and just because you say 0.3 doesn't mean you have to do 0.3. You could go 0.4 and then only do 0.3, and then that's a tighter contact. That'd be fake IPR. Okay. All right. I think we have covered pretty much what I wanted to do on this. We had growth. We had a functional shift. We had class 2 elastics, the expanded arch forms, and how to distinguish. We had bite ramps. We had bonded composite. We had occlusal pads and aligners. We had the difference between actually meted aligner, where you could do maybe the first 12 trays or 14 trays, then you do the for the alignment, then you do your mechanics for the next bunch of trays, and then you finish with a finishing series of trays. So three scans for the same case, but they have different features in each one. I think we covered the functional shift, the features of a functional shift, which is very important. Causes of a functional shift, I said, look first at the second molar, posterior cross bites. Actually, deep bites can, in a severe deep bite, it can cause a functional shift on one side. So terrific. Let me just do one more thing. Let me see here. Oh, this one. No, this doesn't give us the option. Okay, confirm. I don't want all those extra IPR things here. Now what I'm going to do is, let's watch this case treat. Watch the deep bite go away. The upper incisors staying where it is. The lower incisors intruding. The arches are expanding. Okay, and you can study either with a superimposition. So actually, there was some extrusion a little on those upper centrals. So you can study the tooth movements with the superimposition, and in the Ceph overlay, in this feature, you can say, oh, well, why didn't we do bicuspid extraction? Well, you say, okay, here we go. Let's do moderate anchorage. That's why we're pulling the teeth right out of the bone here. Here's the bone over here, and you went too far. That's like too far. So you say, okay, let's do 2.9 moderate to minimum. Okay, that might fly. That might fly. But there's your anchorage planning right there. Okay. In other words, and then if you want, you can compare it to the original, or you can do the same thing over here. You say, well, let me look at 2.9 moderate anchorage versus moderate to minimum. And then you could compare right versus left. Okay? How do we do? Are we making progress here? Okay, well, I think I'm gonna stop the share. And if anybody's still here, here I am. And thank you for devoting your hour and a half to me. Sorry. And I appreciate the opportunity to work with you. And enjoy it again. We'll do it again in 2 weeks. And thanks again for being part of this club. It's appreciative, and I like working with you again. Don McGann, over and out.